Good day, everybody. Welcome to the webinar, Expanded Therapeutic Capabilities in Children and Adults with Narrow Anatomies using a Slimmer ERCP Solution. I am Igor Nemeltsev, Marketing Manager for Pentax in Latin America, and we'd like to welcome you to this webinar. Next. Next. I would like to introduce our moderator and presenter, Dr. Carlos Robles, Chief of Endoscopy Department at the Ecuadorian Institute of Digestive Diseases in Guayaquil, Ecuador. Dr. Robles.
Hello, everybody. Good day, good morning, good afternoon, good evening. Thank you for joining us. I think this is an amazing opportunity for everybody to understand and to know about the new technology that Pentax Medical is introducing in the market now, the Slim Deck. This is a new duodenoscope with capabilities to perform an ERCP and to do some kind of therapeutics, and moreover designed to be used in pediatrics. But one of the objectives of this webinar is to discuss with very good experts, Dr. Valerio Balazzone, that is a consultant surgeon of the Unit of Endoscopy and Surgery at the Bambino Gesù Children's Hospital in Rome, Italy, and Dr. Jeremy Barber, Director of Interventional Endoscopy, the Spectrum Health Butterworth Hospital in Michigan, United States. So thank you to our panelists, to our experts here to discuss and to share with us this great experience with this new technology. So this is the agenda for today. First, we will start to discuss about an ERCP using a Slim Deck duodenoscope for the management of duodenal stenosis, presented by myself. So second, we will perform a presentation of diagnostic pediatric ERCP by Dr. Valerio Balazzone. Third, we will perform a presentation of multiple biliopancreatic malformations in a pediatric patient with recurrent pancreatitis by Dr. Valerio Balazzone. And finally, Dr. Jeremy Barber will present us the use of a slim duodenoscope for ERCP in adult patients with duodenal stricture. So this is the agenda. The idea is to discuss with you and the audience about all the capabilities of this new Slim Deck, this new duodenoscope, and to feel free to do all the questions through our chat. We will start to at the end to perform all the questions to the experts panel, and of course to discuss with you regarding all the questions that you can have regarding this new technology. So please, we can continue with the next slide. So I would like to present to you an ERCP case using a Slim Deck duodenoscope for the management of duodenal stenosis. I believe this is a very good indication for this kind of technology, because in the day-to-day we can be in front of this kind of lesions or strictures in the gastrointestinal tract, and to perform an ERCP becomes sometimes difficult. So as a background, I would like to say to you that the therapy of duodenal strictures may be a challenge during an ERCP. Why? Because sometimes we need to perform dilations, and dilations in duodenal strictures could have a high risk of perforation. So the Slim Deck duodenoscope is a new available therapeutic tool to aid in performing advanced endoscopy procedures in narrow anatomical space. Next slide, please. So this is the patient history and key endoscopy findings. This is 53 years old male with a medical history of diabetes type 2 and hypertension, with history also of allergy to ciprofloxacin. Next slide, please. So as you saw previously in my slide, there was a structure in the duodenal part, and this patient have jaundice. So the patient presents with a 2-week history of nausea and vomiting, with severe abdominal pain and intentional weight loss and jaundice. A CT scan was performed, and the biliary tract was dilated with heterogenic pancreatic head lesion and normal pancreatic duct. So the laboratory data showed CI99 normal, but with the total bilirubin levels of 21.97 milligrams by deciliters. So the US showed an ampullary infiltrative tumor with common bile duct invasion and D3 involvement. Next slide, please. So this is the image of the US that was performed at our institution. So you can see this hypoechogenic lesion coming from the ampullary region and invading both areas. So invading most at all the common bile duct and part of the head of the pancreas. Next slide, please. So we can see here, I think this is the video, yes. So we start to do try to do an ERCP, and one of the important things is to try to be before to perform any drainage, you need to have a very good luminal space in the rest of the gastrointestinal tract, because if not, the patient will start to do vomits, and you know, this was the cause of the vomits in this patient. So we see here the stenosis by using cholangiography and the C-arm and with the contrast. So we try to do first to increase the space here, because to have a good maneuverability to perform the ERCP. So as you can see here, the advantage of this is that the slim deck is near to 10 millimeters of diameter, 11 millimeters of diameter, in contrast to normal duodenal scopes. And this gives us the opportunity to perform this dilation, you see, and then we arrive to pass to the third portion, the duodenal portion, and this was my worry initially. So the idea was to have good dilation and to pass and to see that we will be ready to do it. So we had a little bit difficult to perform the ERCP because the structure and the small space that we have to do the maneuverability. So we perform the ERCP. We do a sphincterotomy, as you can see here, with the standard materials. And we perform a double Guidewire technique. So I put plastic stent in the main pancreatic duct due to the time of manipulation of the papilla and to avoid pancreatitis in this patient. And then we perform a balloon dilation of the structural area just to have good access in the biliary tract, because we didn't have very good access at the beginning. So So you can see here, this is a standard balloon of 10 millimeters. This is just to show you a little bit the capabilities of this slim duodenoscope, because this material normally we use it in therapeutic scopes sometimes, and this is really a therapeutic scope, but with really a slim, no so big distal diameter. So at the end we put this patient was not available to send to surgery because we find some lymph nodes during US that confirm that the patient had metastasis, and then at the end we arrived to put a duodenal metallic stent. Next slide, please. So this is the patient outcome and follow-up. So the endoscopic and fluoroscopic view confirmed the D3 stenosis. The duodenal stenosis was performed a dilation using a 10 to 12 millimeter balloon catheter. The biliary cannulation was performed using a double technique, the double Guidewire technique. We arrived to perform the Sprinkterotomy. We do a drainage of the pancreatic main pancreatic duct using a 5 French by 4 centimeter plastic stent deployment. The ampullary stenosis was performed using a balloon dilation catheter of 6 to 8 millimeter. As step 7, we arrived to put the fully covered metallic stent, 10 by 4 millimeter. The papilla was we take biopsies from the papilla. The distal duodenal stenosis was reached, and dilation was performed using the novel duodenoscope. And finally, a 20 by 9 millimeter metallic duodenal stent was placed. The procedure was successfully performed under endosonography and fluoroscopy guidance. Next slide, please. So the outcome, the clinical and technical success was positive. The symptomatic relief with no post-procedural complication was observed. So the procedure performed was an Ercp with biopsies, biliary cannulation, Sprinkterotomy, duodenal metallic stent placement, and management of D3 stenosis due to an infiltrative ampuloma. And the biopsies confirmed the duodenal papillary adenocarcinoma. Next slide, please. So in summary, we had a distal duodenal dilation that was achieved in a D3 stenotic lesion due to to an infiltrative ampuloma using this new duodenoscope, the slim deck, during Ercp. Finally, just to summarize also the slim deck duodenoscope advantage, this is a high definition image quality. So we can see the small anatomy and detailed visualization. So the appropriate maneuverability of the stand of this duodenoscope was very good. The advantage is just to reduce the cross contamination and easier reprocessing that could be performed in this kind of duodenoscopes. That is something that we need to have in our mind, because the risk of infection is increasing, and moreover in pediatric patients we need to decrease this kind of risk, so we can arrive to do a precise therapeutic performance with this slim duodenoscope, especially during Ercp procedures. And the limitation is that digital single operator cholangioscopy is only we can perform only with the 9 French scope that is, for the moment, I believe it's not available in United States or Europe, but it's available in some other countries. So we have this kind of technology, and we arrived to do, in our experience, cholangioscopy with the 9 French scope. So next slide, please. In conclusion, the slim deck duodenoscope may be a novel, safe, and effective available therapeutic tool to aid in performing advanced endoscopic procedures in patients with duodenal stenosis and in those exhibiting pathological or physiological narrow anatomies. So thank you so much. I would like to invite and provide this opportunity just to invite to be part of our training center in worldwide. This is our web page. We have Endo Club and Endo Live. Endo Live is the first live endoscopy channel. So we perform live therapeutic and endoscopic procedures and diagnosis. So for free. And Endo Club is worldwide club that is just to see new technologies and new advantages we can have with the new technologies and techniques. So we will have our next online live endoscopy course in August 2022 that will be online. So more than 87 countries with more than 5,000 physicians are connected online during these 2 days of full endoscopy procedures, live procedures. So thank you so much for your attention. I would like to continue with our webinar, and I would like to introduce Dr. Valerio Balazzone. So I don't know if there is any kind of question before Dr. Balazzone start his presentation. Any question, please, from the audience? Or
Dr. Robles, do you feel that working in the smaller space with the thinner diameter slim deck is advantageous as far as the risk of perforation?
So the risk of perforation is always there in any kind of procedure of that we will do by endoscopy, even in a colonoscopy or upper endoscopy. But we know that the risk is reduced with the time and experience. What I think is that with this slim duodenoscope, the risk of perforation will decrease when we compare with the normal duodenoscope that we had used during years, because it's almost, I think it's, I don't remember well, Igor, it's 10.8 millimeter of diameter of this scope. So it's not so big like a normal or standard duodenoscope, first. And second, the maneuverability is very good. So we arrived to do good procedures and to do therapeutic, and at the same time to diminish the risk. So I said that during my presentation. I said that to try to do a dilation, the dilation is not necessary to perform a dilation until 15 millimeters that normally we have to do when we are doing ERCP in reduced space like this, narrowing due by stenosis situation. So I believe we will reduce the risk of perforation in these kind of cases. Any other question? So I would like to continue. So we will have one more question at the end for people who is assisting this nice webinar, excellent webinar. So I will let you with Dr. Valerio Balazzone from Bambino Gesù Pediatric Hospital. Dr. Balazzone, we are with you. Thank you.
Hello, thank you very much. Just confirm me that you can hear me, please.
Yes, we can hear you.
Thank you. Thank you also to Pentax for this wonderful opportunity to show our experience and daily practice with this slim scope. I also am connected with my colleagues, the team that is directed by Dr. Dall'Oglio. They will support the discussion and the case presentation. So please go ahead with the first slide. Do you see the slide? I cannot.
Yes, we can see.
Okay. I cannot, so please let me know. So the first patient is a 4-year girl of 13 kilograms that was referred to us for cholangitis and a dilatation of the CBD. So this is the slide with the duodenoscope, the standard duodenoscope that we attempted the first ERCP. And then we tried to remove, and we removed the biliary stones, but it was pretty difficult to evaluate the common channel because it was covered by the scope itself. So we performed a large sphincterotomy and we put the patient on a follow-up. But during this follow-up, the patient referred abdominal pain that was supportive for pancreatitis. So since in small children, you need to intubate and to do a general anesthesia for the cholangio MR, we decided to attempt another ERCP. Please move to the next slide, background. This is a recent publication to stress out the reliability of ERCP in the workup of pancreatobiliary maljunction. In our daily practice, this is the main indication for ERCP in small children, together with biliary atresia and trauma. As demonstrated in this paper, direct cholangiogram is the most reliable tool to confirm the maljunction and to plan the most profitable surgical approach. Please go ahead. You should start the video. So to prevent tracheal compression, the patient is always intubated. So we start in a supine position and almost never rotate the patient. This is the only duodenoscope we have that can be introduced by using the small snorkel. As in this case, we have to wait for the anesthesiologist to adapt the tube position and ventilation after the scope insertion. In our setting, second operator is also a doctor. We could easily pass the pylorus and reach the major papilla. To cannulate, we chose the ultra-thin two-way sphincterotome, and therefore we start with a contrast. And as the maljunction was excluded, we decided to enlarge the sphincterotomy. And as this procedure may be bloody, we never attempt it without a guide wire. We always work with both short and long guide wires according to the situation. And once the deep cannulation is obtained, we enlarge the sphincterotomy, and you will see some sludge eliminated together with the contrast from the CBD. We check for the bleeding and the procedure is over. Please let me know when the video is finished.
Quello che muove il mouse, se sei te, se muove,
No, io.
no? Ripristinato.
Okay, next slide, please. The clinical course was uneventful, and as the pancreatic biliary malfunction was excluded, the patient was candidated to an outpatient follow-up. And if further pancreatitis will happen, we will start the workup for chronic pancreatitis. Please go ahead. Okay, this slide is fine. This is so ERCP is the most profitable tool in the workup of small children with suspect of malfunction. Since generally speaking, the patient is difficult, but the procedure is quite easy. A 3.2 working channel is more than enough for this particular indication, and a smaller tip is an important advance to visualize the common duct. Ultra-thin sphincterotomes carry technical limitations that should be taken into account in the procedural planning. Now I am starting the second case, and then I will pass the word to my colleague. So please show the case presentation 5-year, 15 kilograms slide. No, please go back. Case presentation 5-year, 15 kilograms is the title of the slide. So I'm starting with the second case presentation. Multiple biliary pancreatic malformation in a girl with recurrent pancreatitis. Yes, this one. This was a 5-year girl of 15 kilograms, referred from another hospital for recurrent pancreatitis. An MRCP under general anesthesia was performed, showing a severe collateral dilatation and kinking of the MPD with stones. Small dilatation of MPD and fluid collection were also present at that time. We attempted an ERCP with a standard duodenoscope, but we could not reach the papilla because of an abextrinsic stricture that was shown with contrast into the duodenum during the same procedure. A CT scan confirmed the suspect of annular pancreas. So we attempted a second ERCP with AD32 for the sphincterotomy and the surgical planning. Now please show the video. Same setting of before. You will see a crazy position of the scope to overcome the stricture by the annular pancreas, but we managed to confirm the maljunction and the CBD and to perform a safe sphincterotomy. Sometimes you need to come back into a straight position to lower the elevator and to access the sphincterotome, but if you think that our previous option was only a small 7.5 millimeters duodenoscope with a non-insulated tip, you can understand this is already a big advance. So when the video is finished, please go ahead with the outcome. Okay. So we achieved a technical success with AD32. The major papilla, we could intubate the major papilla with a long position, and the cholangiogram confirmed a common channel that was cannulated with the ultra-thin sphincterotome. Atodani 1C choledochal cyst was also confirmed, so a second malformation associated. And as the sphincterotomy was done, this is very important concept, a safe and elective surgery could be planned. Now go please to the next slide, the surgical management. First, we started with a direct incision of the annular pancreas. Then we resected the dilated CBD. And finally, we reconstructed the anatomy with a Roux and Y hepaticojejunostomy with an open approach. Please, let's move to the last slide. So this kind of patient can have multiple malformations that complicate an already narrowed anatomy. ERCP with sphincterotomy is crucial in the management and planning. Having a 12.5 millimeter disposable tip is a groundbreaking innovation for our practice with this small patient. Thank you. So now, if possible, let's try to switch the microphone to the room where my colleagues are also connected. Hello, can you hear us?
Hello.
Dr. Dall'Oglio, can you hear us?
Very clear. And there's a very special pediatric case in which the opportunity to use a slim duodenoscope really made a difference between an unclear surgical program. On the contrary, we were able to treat the patient correctly with the previous sphincterotomy and clear demonstration of the anatomy. And so at the surgery, we have the correct plane to treat the patients. Thank you.
Okay, Dr. Robles, we have done. I give you back the board to introduce my colleagues,
Well,
Dr. Barber.
Well, thank you.
Sorry for our connection problem.
Thank you, Dr. Balasan. thank you for our audience. We are near 200 people already connected worldwide, so this is amazing. I hope that you are, and we are learning a lot of these experts from worldwide, so from the world. Before to pass to Dr. Jeremy Barber, I have a question for Dr. Balazon. Um, Dr. Balazon, what is the prevalence of an annular pancreas in children, and how frequently does this result in needing an ERCP intervention? This is my first question to you.
And great question. Basically, the malformation itself is pretty rare, and the association of these two malformation even more rare. It's about, there is a recent study with a pathologist. It's about 3 cases of 20,000. So it's pretty rare. But about the second question, in this particular pathology, so maljunction, pancreatobiliary maljunction, the sphincterotomy does not prevent the surgery, because the choledochal cyst itself is the indication for surgery, but it's crucial in the management because it makes surgery elective. So it's pretty important in the diagnostic workup and also in the preventing pancreatitis that make a delay in the surgery.
So, and based to your response that you give us, so science using the slim deck duodenoscope, how many clinical conditions for your pediatric patients can now be managed by ERCP, and which would have otherwise needed surgical intervention?
You still about this the same pathology? You mean pancreatobiliary maljunction?
No, I mean I am talking about all the indications that you will have in ERCP
Okay.
nowadays. Yes.
Okay. So in our endoscopy unit, we have 4 duodenoscope, 3 standard, and only one is the small duodenoscope, the D32. And generally, we use for biliary atresia, maljunction, or pancreatic trauma in small patient, which means that now we can complete a safe procedure in at least 30% of our ERCPs. That before we only had the 7.5 duodenoscope that is, as you know, it's only 2 millimeters working channel. So it's about 30%.
Okay. So thank you. It's a very good number, and I believe that in the next years you will increase the numbers because the indications will start to rise with the time because of new pathologies and new indications. So I would like to introduce now Dr. Jeremy Barber, Director of Therapeutic Endoscopy at Spectrum Health Butterworth Hospital in Michigan. Dr. Jeremy Barber, we are with you now. Thank you for staying with us and to share your experience.
Yeah, thanks, Dr. Robles. Thanks, Dr. Balazoni. So I am going to present now a case of an adult patient with a post-bulbar duodenal stricture. You can go to the next slide. So this was a 53-year-old female who was referred to our practice for choledocholithiasis. She had documented stones noted on MRCP with elevated transaminases and alkaline phosphatase. An attempt was made using a traditional duodenoscope, and during the index ERCP, the picture on the left was noted. A fairly high-grade but very benign appearing post-bulbar duodenal stricture was noted. An attempt was made with the standard duodenoscope and CRE balloon dilation to dilate the stricture to facilitate passage of the duodenoscope. This was unfortunately unsuccessful, and then she was sent to me to use the slim deck. So as Dr. Robles noted in his presentation, dilating duodenal strictures can be very stressful for us because you know, there's only so much room that we have to dilate without the risk of perforation. So I thought this case was perfect for the slim deck, and we were able to do the case, and we'll go ahead and go on to the video here. So here you can see the post-bulbar stricture. Fairly focal in nature and not long segment. This is a 10, 11, 12 CRE balloon dilation being passed through the slim deck. There's the fluoro shot. You'll see the dilation here. Each step of the dilation was held for 30 seconds, and you'll see a slight mucosal disruption when we got up to 12. I did pass a long guide wire through the balloon in order to facilitate passage of the balloon and of the scope. So here you'll see I'm able to manipulate the slim deck scope through the stricture and down into the second, third portion of the duodenum. There is a periambulary duodenal diverticulum off to the right, but not involving the major papilla. Here we'll be using a standard 3.9 French sphincterotome for cannulation with a short wire system. You'll see here, as I engage the papilla, I appear to be in a pretty good cannulation angle, and I'll be able to pass a guide wire here. So as I'm inserting the sphincterotome here, this is a guide wire cannulation without contrast injection. You'll see here with a little bit of sphincterotome manipulation, the guide wire passes easily into the distal channel here. And an X-ray was performed after the guide wire was inserted, indicating that this guide wire was in the pancreatic duct. So after I seat the guide wire and lock it on the endoscope, I'm going to withdraw the catheter and go to a double wire technique. Again, highlighting the utility of the scope, the elevator here is very robust, allowing me to lock the guide wire in exchange to a second guide wire loaded in the sphincterotome. So here utilizing double wire technique. So after I re-engage the papilla, bow the sphincterotome up slightly and advance the second guide wire into the bile duct. So the first guide wire is going to be withdrawn here, indicating just the one wire in the common bile duct. And then from here, I'm going to achieve deep biliary cannulation, and a cholangiogram will be performed. So there's withdrawal of the first guide wire. Now we're just on one wire with the sphincterotome, and we will perform biliary sphincterotomy. So I was able to perform a complete biliary sphincterotomy to the level of the transverse fold here. And I find the maneuverability of the scope with the elevator is excellent. I think the scope performs very well in complex therapeutic procedures. I also do pediatric GI intervention. So in our pediatric patients, we've really adjusted to using this scope as our primary tool for all of our pediatric cases. So a complete biliary sphincterotomy performed. I believe we'll have some fluoroscopy images coming here shortly. Yeah. So showing the bile duct with multiple filling defects, also noted a patent cystic duct with multiple stones in the gallbladder. So a standard standard 9 to 12 extraction balloon is then inserted. I'll be able to withdraw multiple calcified stones here. She had these kind of pearlescent gallstones, and there were quite a few of them in the duct. When I see that with a patent cystic duct, it makes me worry about not leaving a stent, and in this case, we're going to end up placing a stent to protect her from recurrent stones until she has the gallbladder removed. But there'll be multiple stone withdrawals here in this video. Again, I find the camera angle, the position of the scope, maneuverability, and elevator are all excellent. I've had very little limitations. As Dr. Robles noted, a 10 French cholangioscope is the only limitation that I have noted. So we don't have the 9 French single operator cholangioscope available here in the US. But I am able to perform probably 95% of therapeutic ERCPs, even with the scope, given the 3.2 millimeter working channel. Everything short of 10 French will go through the scope without any difficulties. So again, I think we're on to a final balloon sweep here. And then I am going to go ahead and place a stent just to protect the duct, because if we leave this duct unprotected and then the patient has the lap chole, a lot of times we'll see stones fall out of the gallbladder or milk out of the cystic duct during the procedure, and then the patient comes back in with another problem. So I very routinely will place a stent in the setting of a widely patent cystic duct with multiple stones still in the gallbladder. And this is an 8.5 by 7 French stent. As you can see, stent insertion is without any difficulty through that working channel. So overall, I think that my experience over the last 6 months with the scope has been very solid, both in adult and pediatric cases. Adult cases with narrowed anatomy, and then all of our peds cases, we've gone this direction with great success. So I think we're here to just about deploy the stent, and that'll be the end of the video once the stent is deployed. So this patient was then referred for laparoscopic cholecystectomy, and then she'll have a follow-up ERCP 8 weeks from the date of the current ERCP. Next slide, please. So the patient did well, was very technically successful. We were able to clear the bile duct, use a double wire technique to gain access to the bile duct, demonstrating that the locking capabilities of the elevator are very strong. The range of motion on the elevator is great. I'm very satisfied with the way that this iteration is, and not to mention the increased ability to reprocess the scope safely and avoid ERCP related infection in patients. Next slide. I think that wraps up for me. I think we'll turn it back over to Dr. Robles at this point. Thank you, everybody for being here.
So thank you, Jeremy. Excellent presentation. So there was a question from the audience from Dr. Jose Quiroz. So he wants to answer about the double Guidewire technique.
Mm-hmm.
So I think you already answered this kind of question, because you show us how to use the double Guidewire using this scope, even if we have less working channel, diminished working channel. Can you give a little bit more explanation regarding what can we do, not just with double Guidewire technique, regarding putting the stents, or regarding the frames that we need to use, or in our daily practice?
Sure. Yeah. So anything that is 9 French or smaller will go through the channel without difficulty. We've proven that with multiple balloons, dilating balloons. 8.5 French stent is passes very easily. I think the important point for me, I use the elevator a lot to secure the guide wire. I use pretty much almost exclusively short wire. And in locking, I do all of my own exchanges of the devices, and so I'm locking the guide wire with the elevator. You could essentially not have a wire locking mechanism at the insertion, insertion channel for the instrument, because the guide wire is locked by the elevator. And when we're using double wire, it's even more important, because we're going to lock 2 guide wires within the the end of the endoscope at the elevator. So I think overall, this is a nice demonstration of being able to lock the two guide wires. A little background on that technique. I'm sure the vast majority of people probably utilize it, but sometimes it helps to straighten out the distal duct. So by having a wire in the pancreatic duct, it straightens out the bile duct, allowing for easy deep biliary cannulation. So I think this is a nice highlight of that technique.
Yes, I think just to have a good message for the audience that are looking at now is that this slim deck you can use even to put using a double guide wire technique. You can put also stands. You can put 5 French stands, and I do it recently in a case last week. So it will depend of the French of the stand. So you can use the double guide wire and put double stand, but it will depend of the size of the stand that you will use. But of course, you can do it practically as Dr. Barber mentioned to us. You can do it the 90% of the procedures in normal situation with this scope. So we have a question again for the audience, from the audience, for all the 3 physicians. So this is from David Corey in United States. So he says, so one thing that I hear from the colleagues is that plastic elevator is not as strong as metal elevator, not from everyone. What do you think regarding this question? So what do you think regarding the plastic elevator that have nowadays the new technology from Pentax? So the distal single-use elevator. So what do you think, Jeremy, and what do you think, Dr. Balazon? Do you have any problems with the elevator using, for putting, for doing your ERCP, putting plastic or metallic stands?
Yeah, so I was actually involved in some of the. Oh, sorry,
okay,
go ahead, Dr.
Go ahead,
Please go ahead.
Dr. Balazon.
Okay. So we have both the standard and the slim Pentax duodenoscope, and also the other brands scope. So I mean, we can experience sometimes some, as I said before, some latency in the response, especially when the scope has a difficult position like the second case. But it doesn't. The feeling is not about the strength of the material that the tip is made, but just it's just the position of the scope. Basically, this is our feeling, at least.
Dr. Jeremy, what's your experience?
Yeah, so on the current iteration of the deck scope, so the disposable end cap scopes, I see a marked improvement in the strength of that elevator. So I think in some of the very early iterations that I saw, I felt that the elevator needed more strength, and I don't think it's the material as much as the cabling of the elevator itself. I think that they've really worked on that, and the current iteration I think is very solid.
Okay, so regarding my experience, we published the first experience with more than 700 cases in Video GI. I think it was last year in our unit. In our first, with the first generation of standard deck, we didn't have any problems, and we participate also with the University of Texas regarding a multi-center study using this single, elevator distal cap. So for duodenoscopy and ERCP, and I believe there were 2 or 3 cases that they have in Texas. They have some problem, but I believe was the not good insertion of the deck in the distal part. But as I show it in my video, I arrived to do it all the therapeutic, even putting a metallic stand, and with the normal the standard deck, we arrived to put to perform cholangioscopy and all the techniques that we have. So this is not really a limitation, and I believe, as Jeremy also mentioned, it's very solid, and the elevator is very good. It's working very well. So I will pass to the next question. This is from Brad Bat. So he's grateful for this exciting program, but so he mentioned that this 32 French scope, the slim deck, is too large for patients with weights less than 10 kilograms. So I really have a comment regarding this question or comment from Dr. Brad Bat, and this is a comment from all of you, especially to Dr. Balazon. So normally the ASG guidelines recommend to use the standards duodenoscopes in patients with more or more than 9.5 kilograms. So up to 9.5 kilograms, you can use a standard duodenoscope. But I believe with this scope, we can arrive probably to diminish this, to use in less weight patients. What is your regarding this situation? We don't have any clinical evidence, but what do you think?
It's the same situation. We have the last guidelines were 2017, so this scope was not available, and so Andrea Dringali and Mike Thompson say that we should use and the group of Esteban say that we should use 7.5 under 10 kilograms. But yes, this is still a problem because the room for therapeutic procedure is pretty limited. So of course now we need to make some more evidence about this new solution that is available. That of course, as Dr. Bath mentioned, is not. It's not enough for us, maybe, but it's already a big step forward.
So I don't know, just a small comment. I agree with you. I think we need more clinical data, and I don't know. I believe that we need the response from Pentax Medical that is bringing this technology. So this will be used just in 9.5 kilograms, from 9.5 kilogram weight pediatric patients, or you are preparing a clinical evaluation in less kilogram patients. I don't know if somebody from Pentax can tell us something. I believe this is very important to be clear for the audience. Igor. Hello?
Yes, Dr. Robles, I heard your question. Currently, the scope is set for use according to the guidelines, but Pentax will definitely evaluate, make the appropriate evaluations to determine if there is any additional application we can work with. But at this stage, the guidelines will be followed.
So I have a comment from Dr. Luigi Dal Oglio. So about Dr. Brad's question. So they already perform ERCP with Pentax Slim duodenoscope in 5 kilogram patients. So this is a very good data, and I think needs to be already presented in a paper, probably video GI. I believe this will be great because I think solve a lot of problems that we have in this range of patients between 5 kilogram and 9.5 kilogram patients. So it's of course that we don't have all, for neonatology patients or whatever, less than 5 kilogram, but at least I think this technology comes to solve a lot of, a range of patients that were not available to perform any, solution by ERCP. I don't know if there is any comment from Dr. Barber or from Dr. Balazan regarding this situation. So if not, I have a question from Dr. Barber from Brian Edelstein. So do you feel that the narrowing that you saw in your case was a congenital malformation? Could you have doing an incision the structure with a sphincterotomy rather than balloon dilation? This is a question for Dr. Barber.
Dr. Robles, I believe Dr. Barber already, unfortunately, he had to leave already. So,
okay. Okay. So, so just a final comment regarding this new technology. I think it's not just a technology that needs to be used in pediatric patients. We are using now, we have 2 scopes of this slim deck in Ecuador, and we are using in a daily practice for, removal stones or, cases that are in a day-to-day, no hard cases where we need to use, more in more critical situations like cholangiocarcinoma or big cases that we need to use more other kind of techniques. But I believe that for standard techniques and in a daily practice of cholangitis, to put a plastic stent and to perform a sphincterotomy and to retrieve stones, you can use it all also in your clinical practice. So in your unit has been very, very interesting technology, and we are using now not just in this case of pediatric cases, also in the normal daily practice. And it is a good message that I would like that you bring to as a take-home message. So in conclusion, I believe this is a new technology, and as we are looking now, probably we will be used it in less than 9.5 kilograms patients, and for sure we need to evaluate and we need more clinical data for the future, as Pentax already mentioned. For the moment, the indication and formal indication is for 9.5 kilograms and more, and we can use in daily practice in adult patients, but we can use all the techniques and technologies, even digital single operator cholangioscopy with 9.5 range. And I would like to thank you, Dr. Barber and Dr. Balazan. Thank you for being here today. I would like to thank to the Pentax team for this amazing webinar. I think we had in around 200 physicians worldwide connected. So if there is any question, please join your local rep of Pentax Medical. I don't know if there is any comment from the team of Pentax Medical.
And no, Dr. Robles, at this point, only we would like to thank you and Dr. Barber and Dr. Balazone for your participation, and just advise the audience that if they have any further questions, they can post the questions. Thank you very much.
Thank you so much.
Thank you.
Have a good afternoon.
Bye-bye.
Bye-bye.
Bye. Thank you.